The dialysis access is the patient's lifeline. So without access, there is no dialysis. The patient can't survive.
Sounds like a pretty sizable dent that you can put into that $130 billion with this. So pretty exciting.
And so I really wanted to connect all these individuals by having some visible map of the access. So it's almost like a Google Maps of the bloodstream.
What motivated you personally to try to tackle this?
We're trying to extend the life of the access in order to extend the life of the patient. That's really what we're trying to accomplish.
Welcome to the Next Orbit podcast, where connecting healthcare's data is the next frontier. We take you inside conversations with policymakers, healthcare leaders, disruptors, and visionaries who are pushing boundaries in a system that resists change. Explore how modern technology can remove barriers and improve care at scale. It's about ditching inertia and building smarter. For insiders, innovators, and anyone ready to navigate what's next, this is your launchpad. Here is your host, Ben Wade.
Hi, and welcome to another episode of the Next Orbit podcast. Today, we're going to talk health tech in the field of nephrology. It's pretty specific, but it's a specialty that accounts for a disproportionate amount of Medicare spending to the tune of $130 billion annually. Kidney disease is also one of the most complex patient journeys in healthcare. Yet it's a specialty that, at least historically, has shown a more stifled trajectory of innovation and advancement in technology in comparison to the rest of healthcare. Today, we aim to find out what innovations are happening in this field to improve quality of care for patients while also bending the bell curve in Medicare spending. I was lucky enough to find a practicing interventional radiologist, an innovator, and an Air Force veteran to help us navigate. Dr. Shannon Beardsley, thank you for being here.
Thanks, Ben. Glad to be here.
Yeah, so Dr. Beardsley, as an interventional radiologist specializing in dialysis access, I think you have a unique perspective. On one hand, you've seen incredible innovation in the radiology space. So one thing that comes to mind is AI for interpretations and early detection. But when you zoom in on nephrology and treating kidney disease, the landscape looks much different. Medicare is spending $130 billion annually. That means 1 out of every $5 is going towards kidney care. And for perspective, when compared to other specialties responsible for treating chronic conditions like cardiology, neurology, oncology, this specialty is still consuming 2 to 4 times more in Medicare spending. So I'll start by asking, as the largest expense line in Medicare's balance sheet and one of healthcare's hardest patient journeys, why is nephrology not the most innovative specialty in healthcare?
Yeah, that's a good question. So I think part of it stems with the different silos, different groups that are seeing the patient and getting reimbursed by different methods from the government. Additionally, it's a capitated or it's a bundled payment that goes to the dialysis center for the treatment. And so that payment is set by the government. There's a little bit of an increase each year, based on cost of living adjustments, whatnot, but it's about $270 per dialysis session. And so out of that one payment for each treatment, you have to pay for staff, you have to pay for the supplies for the dialysis session itself, all the equipment. It's really a one payment for each session. And if everything goes great, then there may be a little bit of a small profit margin. If not, if there's a complication, then that's going to cut into that profit for the center, their operating profit. And so by trying to innovate in that area, you're often increasing the cost to the dialysis center for that product because what you're innovating with your new device, your new drug, your new treatment is not going to be captured in that bundled payment. So anything outside of that bundle is an extra cost to the dialysis center. So that's one of the biggest impediments to innovation. Another big problem with the innovation is that the manufacturers of the innovators are asked for the proof of the cost savings before it's adopted by, let's say, the government. Yet you need to have good adoption, widespread use before you can really start to evaluate what the cost savings are. So this obstacle, this hurdle also stifles a lot of innovation. And there are some ways to navigate that, but it's tricky and it's not as straightforward as it could otherwise be.
I guess one of the questions I have, Dr. Beardsley, is what motivated you personally to try to tackle this, this challenge or to address this opportunity, if you looked at it that way?
Sure.
What kind of got you motivated here to do this?
Well, personally, I just have a strong interest in dialysis patients. I have been working with dialysis patients my entire life. My first job out of high school, I actually was a reuse technician. I was working in a dialysis center because I was interested in medical school. I wanted to get some practice, some experience in the healthcare industry. And so in my local town, I got employed by a dialysis center there. And since then, I've worked under some very good innovators in the dialysis space up at the University of Pennsylvania, Dr. Scott Terratola. And so I've always been involved with dialysis patients. My job as an interventional radiologist, I have a broad skill set in doing minimally invasive procedures, but a big part of that is managing dialysis access. So dialysis catheters, I place them, I fix them if they're not working. Same with fistulas and grafts. I don't create them surgically. That's for a surgeon, but I deal with all the complications. And so I've been involved with dialysis patients pretty much my entire life. And so I see the problems. I see the problems from my side in the interventional lab, but I also have my prior experience in the dialysis center. So I know a little bit about what goes on in the dialysis center. So I can kind of see both sides of the problem. And I think that's given me a little bit of insight into possible solutions.
That's great. I like the fact that you've been, just personally, I like the fact that you've been involved so early. I do know in my own personal life, I've known several people that I care about who are dear to me that deal with diabetes. They haven't gotten to the point where they need dialysis, although I have had a good friend from church who passed away a few years back who did eventually get to the point where she needed to be on dialysis and saw kind of the personal side of it. And so I appreciate the work that you're doing.
Dr. Beardsley, you mentioned bundled payments. How does it work? How is new innovations or how are they funded through the dialysis center if it's not covered in the bundled payment?
Yeah, well, so the bundled payment is really designed to capture all the costs, to reimburse for all the costs of the dialysis session. That's everything from equipment, supplies, nursing, the dialysis machine, maintenance, electricity, everything. And so if there's innovation that's, contemplated of a product that's already reimbursed in the bundle, but it's more expensive, then it's very difficult to get that into the bundle because the dialysis center will see that as more, financial loss. Okay. So they're not going to want to transition to a product that they already are reimbursing, like a gauze, some gauze, a new brand of gauze that's a little bit more expensive. That's very difficult. But if there's something that's outside the bundle, a new innovation, then there are a couple methods to get that into the reimbursement. And one of that is for drugs, it's called the TDAPA, the Transitional Drug Add-on Payment System. And that's a process where a drug is evaluated. There's a process to get it approved for this 2-year trial where the dialysis center will be reimbursed for 65% of the cost of that drug. And so with that, it allows the drug to be used. It allows more data to be gathered so that the government can ultimately make a decision. Is that something that they want to continue reimbursing after that 2-year period sunsets? Another program is the TPNIES, which is the Transitional Payment Add-on for new and innovative equipments and supplies. And so this is for devices, medical devices, software, things that are outside of the drug category, which may improve outcomes in the dialysis center. Again, it's very similar to the drug program. It's a 2-year award where the CMS will reimburse 65% of it to the dialysis center. It's a way to get the product used and get some wider adoption to start gathering data to prove outcomes. Those are the two main ways to ultimately get reimbursed if you can make it through that.
So Dr. Beardsley, we brought you on to talk about innovation. Perhaps you can share a little bit about what you're doing and what your journey's been like in bringing a new product to market.
Sure. One of the things, as I told you, one of the things I do in my day job is I repair dialysis fistulas and grafts. So a fistula is a connection between an artery and a vein where the vein will dilate a little bit and allow it to be palpated and used for dialysis. So the technicians are placing large bore needles into the vein in order to get blood for the dialysis machine. And a graft is where you have a synthetic piece of material like vortex, like a tube that's connecting an artery and a vein. It's used for the same purpose. It's for putting needles into to get blood. And so I repair them, and I kind of have recognized that there's not really a way for me to effectively communicate with the dialysis center staff. So if I see a patient who has a problem and I can recognize that the problem is because of puncturing in one particular area too many times so that it weakens that vein or that graft, I can't really communicate that back to the dialysis center. And if I see something angiographically, which is where I take x-rays with contrast dye in the access in the vein, I might see outpouchings or aneurysms or areas of scarring, narrowing. And these are areas that I might want to flag so that the dialysis technician doesn't place a needle there because it will create more trauma. There's no way for me to do that. And so, having worked in the dialysis center, I kind of know a little bit about what I'm seeing there as a technician. And I visited dialysis centers, of course, as part of my job, just to get a good understanding. And so I really wanted to connect all these individuals by having some visible map of the access. So it's almost like a Google Maps of the bloodstream. And so what I contemplated was having a photographic image of the patient's arm. So what the cannulator, what the technician would see in the dialysis center, where I can then overlay the historic record of all the cannulation points and all the hazards, so that I can see when the patient's with me in the interventional lab, I can see what they're doing in the dialysis center by looking at that image. And when they're in the dialysis center, they can see what I've done as an interventionalist, and also they can see their own records. So as it stands currently, they only can look at the arm and visibly see where there might be a scab from the prior puncture, which may go away after 4 or 5 days. And so they don't really know the historic record. But with what I wanted to do is provide a way for them to see a year of data, where those needles have been over a year, where are areas being overutilized, what areas are not being punctured very much, and why. And so I developed a software product called Ristra, which allows you with a single image to see all that information. So it really adds to the situational awareness of the technicians who are placing needles into the access to be able to know what they've done in the past, what areas are hazards, and to avoid those, and to follow the best practice of access.
Yeah, Dr. Beardsley, if you wouldn't mind sharing, what is the impact on the patient if they have access, if the caregivers have access to this kind of technology? What's the, both from, whether it be physical pain, less trips to the ER?
Yeah.
How does this impact the patient at the end of the day?
Well, the dialysis access is the patient's lifeline. So without access, there is no dialysis. The patient can't survive. And so the problem is the patients have limited veins available. So they may start in a distal extremity. They might start in the forearm. And if that access is no longer able to be used from scarring or clotting off, it can't be salvaged, we then move up the arm. And we start at the non-dominant arm, and then we go to the dominant arm. And then you may run out of upper extremity. You might have to go to the lower extremity. But ultimately, you can run out of dialysis access locations. And so what we hope to do is minimize the complications that shorten the lifespan of the access. And we do that by allowing the technicians to better follow the proven safer technique of what's called rope ladder, which is basically evenly rotating the puncture sites along the access and avoiding area puncture, which is basically repetitively puncturing the same area. So imagine if you're sticking a push pin in a corkboard.
Yeah.
And pushing the pin in the same spot over and over and over again. Pretty soon the pieces of cork are going to fall out and you're not going to be able to keep the pin in that location. However, if you were to put that pin in every spot along that corkboard over the life of that corkboard, you would barely even know that there was ever a pin there. So that's kind of the same idea here we're trying to capture. Can we make sure that each needle is placed along that access, the fewest number of punctures at every location to extend the life of that access, to create the least amount of trauma? And so with that, we're avoiding clotting of the access, scarring of the access where you have narrowing, which reduces the flow and it leads to a clotting event. We're preventing aneurysms, which are outpouchings of the vessel because of weakening from repetitive puncture. And we're preventing infiltrations, which are where you have difficult accesses for these other reasons, and the needle goes through and through or punctures through the wall and allows blood to leak out into the soft tissues. And so all of these events are going to lead to an ambulance trip to the emergency room and then to an interventionalist or a surgeon to try to repair it. If it can't be repaired, then they go place a new access in the other arm or in the upper arm, and you now given up that one site forever. And so we're trying to extend the life of the access in order to extend the life of the patient. That's really what we're trying to accomplish.
Correct me if I'm wrong here, but it also sounds like, not that the most important thing probably to the patient is maintaining life until they can get a transplant if they're eligible for that. But yes. I'm also assuming that, there could be a lot of additional discomfort and there may be hospitalizations required for some of this, and that avoiding all of that also improves quality of life for the patient. So it's not just potentially bending the cost curve, but also in addition to extending their life till, they can receive another intervention if needed or if they're eligible, but also ensures that their current life circumstances are better because you're able to work collaboratively through that communication mechanism with the dialysis center to ensure that they're following best practices because they have the information to do so.
When you end up going to the hospital, there's the aggravation of that, the impact to your life, the pain of more needle punctures and balloons and treatments in the interventional lab, possibly going to surgery. Of course, you don't go directly to surgery. You have to be scheduled. So there's several days where you might need a temporizing catheter. So you may have to have another procedure to place a catheter in your neck. So now you have a large bore catheter coming out of your neck. There's complications from that, perforation, infection. All of these things are huge impacts on the life of the dialysis patient who really just wants to live their life as any other person. However, right. 3 times a week, they have to go into the dialysis center and spend, a good part of their day sitting in a chair tethered to a machine that's cleaning their blood. So yeah, anything that we can do to improve the life of the dialysis patient, their experience is hugely important.
And I read somewhere that on average, a dialysis patient skips about 7 appointments a year, which sounds low, but it also was indicative of the fact that increases the likelihood that they'll have a hospitalization.
That's right.
I think it was like anywhere from, 1.5 to 2-fold increase in hospitalizations within the next 7 days in the same paper that I was looking at. And I bring that up because I wonder, from your experience, is that driven in part by the discomfort if things are handled improperly? Like I know for myself, I hate it when they puncture all the way through a vein when they're trying to draw blood on me, and then you have like a big bruise, and that's uncomfortable. Is that in part driven by that in your experience? And does that also help then ensure that they're more likely to follow through and go to all their appointments? I'm confident they have other life circumstances that affect that too, but does this help as well?
I think it's multifactorial, as you alluded to there. I think there's often transportation issues, other life events that are conflicting. Missing a dialysis treatment, there's not always an immediate impact to the patient. So for them to not go to dialysis, on Monday morning, it's not like Monday evening something terrible might happen. Right. However, the biggest problem is you're getting some changes in your fluid volumes. And so the next dialysis session may have to be more aggressive to remove that extra fluid off or to run the dialysis treatment a little bit longer to get the additional toxins out of your body. And so it's this roller coaster ride that they're on. And so missing a session makes the next session a little more traumatic, a little more difficult. And so I think that's a big part of it. Now, can their experience in the dialysis center, like with our product, can that make it more likely that they'll go to dialysis? I think it plays a role. I think it contributes to the overall experience. You do want to, the dialysis centers try to have a clean environment. They try to have comfortable chairs. There is a little bit of a social experience as well. The technicians that are seeing the patients, checking them in, getting their vitals and hooking them up to the machine. Although it may not be the same person each session, it's usually a group of people that may rotate that they know over time, develop relationships with. I know when I was working in a dialysis center, that was my first experience with, death and dying. I mean, I bonded with a lot of my patients who I was working with every day, all day long, who were coming in 3 times a week for 4 to 5 hours. And so I got to know them because I'm talking to them during the day.
Yeah.
And so when they don't show up, during a dialysis session, and then I find out a few days later that they never made it out of the hospital, it's, it's sad, but it's the reality of dialysis. And so I think you want to make the experience as pleasant, and you want to impact their normal life events, a normal life of a person, as little as possible.
Yeah.
You can never have, of course it's a huge impact, but you just want to optimize it the best you can.
Yeah. That's a really good point.
Dr. Beardsley, I'd like to get into the tech for just a little bit. I'm not familiar. I've never seen a dialysis management platform or dialysis access management platform. What does the technology look like, and how does it operate within the greater tech stack at the dialysis center, at the nephrology office?
Sure. So the technician who will be placing the patient on dialysis, doing the cannulation, placing the needles into the arm, our software is cloud-based and it is displayed on a tablet. So we provide a tablet. The technician opens up the tablet, pulls the patient's name from a list, the patient that they're working with. And when they select that patient, it'll open up an image. The image is of that patient's access, which is already loaded up into the system when the patient was onboarded. And that access has an overlay, a 6-week running record of all the cannulation points. And so the cannulation points are basically color-coded. They're sized, a certain size that you can see them on the arm. The color changes over time. So within 0 to 2 weeks, the color of the axis is going to be red, of the location will be red. After that, it changes to yellow, and then it changes to green. And then after 6 weeks, it goes away. So just by looking at the image of the arm, when they're standing in front of the patient, they can easily see what the last 6-week history of cannulation has been and the direction, the trend of what they're doing. By hitting a toggle switch, they can also pull up a 6-month or a 12-month record, like a heat map of color coding of the axis cannulation density. So areas that are overutilized, even though you may not see any skin changes yet, those areas will show as red. And areas that are underutilized will show more towards a faint yellow. And so if you had a patient who was perfectly managed, evenly rotated, they would just have an even yellow color over their axis. If you had an patient who was getting area puncture exclusively, then you would have 2 red zones that would show on the arm. And so just by a visual look at that, you can easily see what the record has been. So the important part about Ristra is it fits into the normal dialysis flow, the normal onboarding of the patient flow without interfering. It's basically the technician already has to evaluate the arm before they cannulate. So this is one extra piece of information. They can glance at that and see the historic record of where they've cannulated before. They use that to decide where they want to place the needles. They then place the needles, secure the needles, turn the machine on, and then they go back to the software tablet and they just touch where they place the artery and where they place the vein needle and hit enter.
Really?
That's all they do. So it's very minimal impact to the normal workflow. Now that is now going to a database, and so it's available for the next session to add to the information. So it's a very simple tool, but it's just a tool that does not exist right now. There's paper records where sometimes someone who will draw a picture of the arm, very cartoon-like picture, and may show some areas that are hazards. Some dialysis centers will mark up the patient with a marker, like a Sharpie, and show areas on the arm that you should avoid and what the historic record has been a little bit. Take a picture of it on the patient's phone so that when the patient comes in next, they could show the picture and say, hey, my nephrologist said not to puncture here. So this is kind of some of the ways communication is done now. It's not the right way to communicate medical information among professionals.
That makes sense. And, one of the challenges I'm hearing is that, you've got multiple different stakeholders on the care team, or, you've got a nephrologist, you've got the dialysis folks. I would guess one of the challenges is getting this software, getting this tablet into the hands of everyone on the care team, when oftentimes they may not be under the same organizational umbrella or part of the same health system that would be adopting that software. Yeah. Is that a safe assessment?
Yeah, that's true. And so our software could be pulled up on desktop as well. So like the administrators in the dialysis center can pull it up. There's a dashboard that has some dashboard features that are useful for following their clinic performance and following the performance of each technician, and also looking at each patient to decide whether they're falling into the normal parameters. And so they can take action to correct that. The software is not currently configured to be viewable outside the facility by a nephrologist. Certainly we can give them access if they're part of the team, and that's something that the dialysis center can choose to do. But the other part of the puzzle with our software would be getting it into the hands of the interventionalist like myself or the surgeon who is going to be working on the failed access. And we would also want to know as much information as we can about what's being done in the dialysis center. So strategically, we have our current product, and we feel it's most important to get into the dialysis center itself, where the value for what we have is going to be the greatest direct impact to the patient will be the features that we currently have, which is mapping the cannulation record and showing the density of the distribution on the heat map. And so as we get a foothold there as a startup company, we could then start to expand into the hospital setting or the interventional lab setting.
And so when you talk about those other settings, do you mean integrating your software into the existing EMR system, or?
Yeah.
Okay.
Yeah, I think that would be ideal, is to be able to communicate both ways, right? So it could be attached to an EMR, some of the EMR systems that hospitals are using already, or it could be a standalone access, log into a website where they have access either from a code brought by the patient, or if there's a relationship already established where we've onboarded those physicians, then we would have a system set up where that patient is already populated into the system during that appointment. And so the physician can then just log in, pull up the record for that patient, and make any inputs that he needs to make after the intervention. But this is definitely for us down the road to manage that user interface for the surgeon or for the interventionalist. That's after we've kind of proven ourselves the value that we're providing in the dialysis center itself.
Okay, well, this has been really interesting, and I've thought a lot since we were talking about having you come on, Dr. Beardsley, about the impact that Ristra could have when it comes to, the costs related to this from a kind of a national level. And so I looked at some studies and I did some back of the napkin calculations, and I'll just kind of share those briefly, but I'd love to hear whether or not that resonates with you and kind of what you're seeing and what you see the potential. And so from my side, I looked at some things from the Kaiser Family Foundation that indicated that, a stay in the hospital is typically, about $3,000 a day in the US. I looked at some things that have been published with I want to make sure I get this right. I'm trying to remember who it was. Oh yeah, it was the National Institute of Diabetes, Digestive and Kidney Diseases. They have their annual data report. I took a look at that, and they indicated that there's about 815,000 Medicare beneficiaries with end-stage renal disease, which is, requires dialysis in all cases until they can get a transplant. And so kind of thinking about that patient population and those costs, the other thing that I read in one of the other studies is that, a patient who's on dialysis will often spend 11 days or more in the hospital. And we talked a little bit about that and why that happens. But looking at those numbers, if you could even split that in half, which was kind of my just rough estimate on the back of the napkin, I came up with a savings of about $13 billion a year. So does that resonate? And how would you actually go about looking at what the potential impact from a cost perspective would be?
Yeah, it does. I mean, we can come at those numbers in many different directions, but those are close to the numbers we got of the overall cost to the healthcare system. There's costs of ambulance transportation to the hospital, the actual hospitalization cost, the cost of the procedures themselves, which may be an intervention as simple as doing an angiogram and showing that there's nothing wrong with the access, all the way up to a new surgical fistula that needs to be created with several days of having a catheter in. And so if you look at the overall cost, those numbers are, I think, pretty close to what we've calculated as well. Now, we certainly are not saying that we're going to reduce the complications by 50%. We don't know yet. We haven't done a large outcome study to show that. But We do know some of the data on outcomes of area puncture versus good rope ladder, distribution technique. And those numbers are very significant. So I think we can make a big impact there. Now, Ristra, our software really impacts a lot of different levels. So for the bundled side, the dialysis centers also get penalized if they're not meeting certain quality measures, such as hospitalizations, access failures, that sort of thing. So not only can we reduce the cost of the complication itself in the hospital, something that's, CMS is reimbursing to the interventionalist or to the hospital itself, but also we can help with the dialysis center by meeting those performance parameters and reducing the penalties that they may undergo. We also can help with the physicians, because a lot of the physicians now, nephrologists, are getting capitated payments for their patients. And those can be either for patients who are on renal failure or end-stage renal disease, or patients who have renal insufficiency. There's a slight difference in the payments, but they are basically anything we can do to minimize the overall expense of that patient is going to also result in shared savings benefits to the nephrologist as well. And then finally, if you look at the government, our product Ristra can reduce, as we mentioned, those hospital costs. Now you have government payers who are also going to benefit. And it's really being able to get insight into the data of what Ristra is doing. What are the complications that we're able to prevent? What can we do to offset the penalties in the dialysis center? What can we do to increase the shared savings for the nephrologists and the kidney care organizations that are forming to, deliver good value-based care? So we don't have all the answers yet to how we can impact this, but we know it will have an impact. And we need to measure this because everything is going to depend on getting good data and being able to show how we actually do impact the bottom line for all these players in the dialysis space.
Sounds like a pretty sizable dent that you can put into that $130 billion with this. So pretty exciting. You mentioned earlier TPNIES. Can you explain to me what that is a little bit?
Sure. So that stands for Transitional Add-on Payment for New and Innovative Equipment and Supplies. And so it's one of the methods that the government has set up to allow innovation into the dialysis space. And what you do is you have a product which has to meet certain criteria. It has to be innovative. It has to be FDA approved. It has to recently be entering the market. So it has to be something new. And you compete. You submit an application to the government. They determine whether it qualifies to receive this award. If they grant you the award, then in the following year and for 2 years, they will reimburse the dialysis center for the use of that device or equipment at 65% of the cost. And the cost, there's a process for determining the cost, but essentially it will be reimbursing the dialysis center for the cost of that device for 2 years. And that allows you to get the product used, adopted a little bit wider in the dialysis space in the dialysis centers to start gathering data. And that data will then be presented to the government after that 2-year period to try to determine whether it actually does reduce the cost or improve the patient's life. And the government will make a determination of whether they will continue to reimburse that going forward. And that could be within the bundle by increasing the actual dollar value of the bundle, which is currently around $270. So maybe they increase it to $275. Or it could be outside the bundles. Some devices may be paid for outside the bundle under a specific grant. And so actually that's the way we probably will be trying to get into the dialysis space reimbursement, is to compete for that TPNIES award and then getting a wider adoption and using that information to try to eventually get a reimbursable code so that when the dialysis center is using our software to help the patient reduce outcomes or reduce negative outcomes, they will get reimbursed for that use. It's something that will be billable to the government.
And is that a single award recipient per year?
No.
Okay.
No, it's not. There's not a set budget for it, but it is a competition to get the grant, but you're not competing. It's not a zero sum game. Multiple companies can win that.
Okay, great.
And it seems like one of the steps that you'd want to take, and I think you'd mentioned this in a conversation we had prior to this, but I wanted to bring it in here if we could, Dr. Beardsley, is you talked about kind of getting the data to back some of this up. Could you tell us a little bit about what you're doing and how you're approaching that?
Yeah. So what we are doing right now is looking to various dialysis organizations, some small and mid-level organizations and some larger, to try to find a good partner in order to use our software under a study and to start to gather data over a period of time, 12 months, maybe 18 months, depending on the number of patients. That'll determine how long we have to go. And also, of course, how effective our software is at reducing complications. So the larger number of patients, the more effect we have in reducing complications, the shorter the study would have to run. And so there's a couple ways to do it. You could do a study where you are using it in a number of centers, and then you compare that to a historic record of the same centers previously, or you could have a group of centers using another group that aren't and do a comparison side to side to try to show, basically we were hoping to show a statistically significant reduction in complications and to be able to quantify that as a cost savings to the system so that we can use that cost savings in negotiations with the government to determine what a fair reimbursement would be that allows everybody to win. And so that's kind of our strategy, is to, number one, try to get a study underway now, also go through the TPNES program to try to get some wider adoption. Of course, all that data will be used as well. And really, it's a large amount of data that we'll be gathering. Each patient gets, 3 dialysis sessions per week, 6 punctures. And so all that data will be correlated with outcomes to try to find out what the puncture record, more insight into the puncture record means as far as reducing complications. How does that change the actual, process at the cannulator, the dialysis technician or nurse doing the cannulating? How does it change their experience? How does it change their procedure to reduce the negative outcomes?
That sounds pretty exciting. And I'm not, because I'm a tech nerd, but if I were, interested, maybe I'm, chief medical officer for a dialysis center, what's kind of the pitch to me? Like, why would I participate? And, and if I am interested in talking with you, like, how would I go about doing that to kind of say, hey, you know what, actually, I'd be interested in having this conversation with you and your company about being a part of that study?
Yeah, well, there's many ways to reach us, or through our website, or people sometimes come across me on LinkedIn. We're doing outreach right now to a lot of the dialysis centers as well to try to proactively go out and inform them about our software. But the value to the dialysis center is really that it's giving them insight into the cannulation history of their patients. They already are instructing their technicians on how to cannulate. They're instructed that they should follow rope ladder technique and they should avoid area puncture. But there's no mechanism to track what's being done in real time or even historically. So the technician is the one placing the needles, and then there's no way to go back and see what has been going on with that patient or that technician over the past several months. There's no way to know. So we're providing an immediate feedback loop that administration can look at to be able to see what's actually being done with the interaction with the patient. And so that's our biggest value right there. And so this, for example, if a patient has a slight aneurysmal dilation in their arm, and the technician knows that they're supposed to rotate, and so they go to another area that's not dilated, the patient may question that. They may ask the technician, why are you puncturing over here? Because last week, Sally got right there, no problem. And so there's a gentle pressure on the technician to go where they punctured before as well. And so by having this software tool available in the interaction itself between the patient and the technician, there's an education process for the technician, and there's also education process for the patient. And so we hope, all these different benefits of the software in the actual front line of the interaction with the patient is going to drive behavior more towards the rope ladder technique, avoiding area puncture, which already has proven benefit of reducing complications. So that's kind of where our value is right now. Even before we've proven that value, that's our value proposition to the dialysis center, is that insight, closing that feedback loop.
Okay. And I guess, kind of in my own business and the things that we do, sometimes we do kind of a loss leader approach. I'm not saying you should do that. I'm just asking kind of if you're pitching to them and saying, okay, please, we do want you to be one of the first ones that we work with on this. We want you to be a part of this study. Is there anything additional that you're pitching to them to help them consider this? Yeah.
One of the strongest pitches that I give for the dialysis centers who are early adopters is not only do you get the benefit that I just discussed, but you are going to design the product with us. That is very valuable. And we have taken advantage of that. These technicians, we thought actually the technicians would be the biggest pushback against this because they're the ones that are changing their behavior. The administrators get the additional information when they're sitting on their desk, looking at things weekly. The nephrologist may get that information as well, but the technician has to, change their behavior a little bit. It's an extra step for them, for sure. It's a change in the way things were, and that's always frustrating when there's change. But they've been our biggest advocates. I mean, they love this. And, the dialysis technician often doesn't have the greatest amount of training. Okay. There's some turnover. They're actually the ones on the front line with the patient sticking needles in them. And so that's very stressful for them. And so to have a tool that helps to guide them, that they can follow as a reference to know what the technician did before because they may not have been with that patient the day before. It might have been somebody else. So to be able to look and see what was done, to see what the record is, to know they're providing the best care for that patient is actually very comforting to them. That's what we've heard from the technicians. And so we let them know that. And we also let them know that this is a living software product and we are not in the dialysis center like the technician is. So we empower them to give us information. What do you want to see?
Yeah.
And we've already implemented many of those solutions. They wanted to see numbers for the last 1, 2, and 3 puncture sites. We implemented that. They wanted to be able, this was a surprise to us. They wanted to be able to designate hazard areas. So we envisioned the surgeon or the interventionalist designating where there's a hazard, but the technician said, well, I know where there's an area that's difficult for me to access or an area that I often infiltrate. I want to be able to identify that for the technician who's coming on Monday when I'm not going to be here. And so we implemented a way for them to flag an area and give a note so that when the other technician logs in, that note will pop up and it will show an area on the arm where that hazard exists. It's a living software application. We're building it with them. We're building it to their specifications. And that seems to be well received by our early adopters.
Yeah, it sounds to me like another advantage potentially would relate to that turnover you talked about, which is that if I'm a technician and I'm placing the needles and doing the work, I'm going to feel more motivated to stay with an organization that I feel like A, is providing me better tools, and B, that I actually get some say, as you talked about, in how that tool evolves over time. And I realize that's a short-term thing in some ways, but that does seem like an immediate benefit that would probably also go to my bottom line in terms of not dealing with the turnover and maybe having to figure out how to have the staffing that I need on each of the shifts that I need. So that also seems like, I just wanted to flag, it sounds to me like naively maybe, but that's what sounds like another big benefit of participating in this. So that's pretty cool. Thank you.
One other area that I should mention is one of the lead technicians in one of our centers was educating a patient who is going to be transitioning to home dialysis. And although we knew that our software will have some application for home dialysis patients who are actually cannulating at home, because it may give visibility to the dialysis center staff and the nephrologist what that patient is doing in their home setting. However, they were using our software to help educate the patient about how they should be puncturing the access by showing the record of what they've been doing, showing them how they rotate and the reason that they're doing it as a teaching aid, so that when the patient goes home, although they don't have the Ristra software at home currently, they have that knowledge now of the reason to rotate, and they have that visualization of their mind of the purpose of it and what it may look like. So that was unexpected, and that also came from the dialysis center. So these are all huge benefits for us. I mean, to take this information from the front lines and be able to think about how we can implement solutions that solve those problems.
Now, this has been really interesting, Dr. Beardsley. Thank you for giving us an opportunity to look behind the curtain on what it takes to innovate in the specialty that you're in. And, I'm sure Mike and I would like to invite you back on in the future, maybe with your CTO, so we can pepper you with some technology questions. But no, really appreciate you being here. Excited to watch how Ristra grows. And, with that, I will, this concludes another episode of the Next Orbit podcast. Until next time.
Thank you very much.
The Next Orbit podcast requires more than a conversation. It takes action, research, and collective wisdom. If today's episode resonated with you, we'd love to hear your insights. Join the conversation and help us shape the future together. We'll be back with more stories, strategies, and real-world solutions that are making a difference. In the meantime, be sure to subscribe, write a review, and share it with someone you think would benefit. Thanks for listening, and we'll see you on the next episode.